My name is Joseph Lotosky, and I will be presenting a lecture on Alzheimer's dementia, specifically pertaining to late-onset Alzheimer's dementia. So I'd like to begin by discussing the diagnostic criteria as based upon the DSM-5's definitions of what it takes to be diagnosed with dementia. And Alzheimer's dementia is a more general term used for the overarching word dementia, in the sense that when other dementias are ruled out, such as Lewy body dementia, doctors will ascribe the diagnosis as being Alzheimer's dementia, as it is the most prominent form of dementia currently known to the medical community. The first criteria that I'd like to talk about regarding Alzheimer's dementia is that there is evidence of significant cognitive decline in at least one cognitive domain. Usually, the domain affected pertains to memory and learning, but other domains are also seen. There are some visuospatial deficits seen. They are more rare, but deficits in those domains are seen as well. And the second criteria I'd like to discuss is decline and deficits interfere with everyday life. That is, someone with the deficits is not able to function. They are not able to get up in the morning, remember what they have to do that day. Even if they have a list planned out for their day, they need extra help, extra care to get them through the day. The third criteria I'd like to talk about is that the deficits do not occur in the context of a delirium. And a delirium is a state of mental abnormalities in thoughts, sometimes caused by medications, lack of sleep, environmental pollutants. But to be diagnosed with dementia, specifically Alzheimer's dementia in late onset, the deficits cannot be explained by delirium. And the last criteria I'd like to discuss is that no other mental illness or environmental factor best explains the deficits. And this means that the patient, if they were diagnosed with, say, a mood disorder or something else, and they've controlled for those symptoms that are present in the other disorder, or say if they were under the influence of certain drugs and psychotropics, once they control for that, remove the patient from those situations, those settings, and like I said, control for the symptoms of other illnesses, and these symptoms are still shown, the cognitive deficits and declines are still there, then the doctor will proceed with the diagnosis of dementia. So I want to talk a little bit about the history of Alzheimer's dementia. And the first reported case was in 1906 by Dr. Alzheimer, and he noticed a patient who was, had some memory complaints, wasn't able to really function in day-to-day life, and the patient ended up dying. And like I said, there was memory loss, language problems, unpredictable behavior, and these are hallmark signs of Alzheimer's dementia. And then Dr. Alzheimer went on to do brain pathology and discovered abnormal clumps, which would later be learned are known to be amyloid plaques, and also tangles of fibers, which are now known in the medical community as tau/and/or neurofibrillary tangles. So I'd like to just quickly and briefly talk about the numbers. The average onset is between 65 to 75 years old. Alzheimer's dementia affects between 5 to 6 million individuals in the US alone. The cognitive declines are not usually noticed until 10 years after the onset of neurological damage, and that's as measured by beta amyloid plaque deposits and neurofibrillary tangles beginning to form. And women are more likely to develop Alzheimer's dementia, late onset specifically, than are men. And if you look at the graph in the top right-hand corner, Hispanics and African Americans are more susceptible to Alzheimer's dementia than our white Americans are. I'd like to discuss now the neuropathology of Alzheimer's dementia. So the plaques and the taus are the hallmark neuropathogens that are currently being investigated in Alzheimer's dementia, and they begin to form in the temporal and posterior association cortex. And over time, it progresses to the frontal cortex, where a lot more of memory processing and working memory is done, and studies suggest that this is where cognitively normal individuals hold most of the memory in regards to these specific tasks, and that may explain the time delay in the proliferation of plaques, tangles, and the cognitive deficits seen. And unsurprisingly, sensory cortex is largely spared by Alzheimer's dementia and neuropathology, and I'm not exactly sure why, but it would explain why sensory deficits are not a prominent symptom and cause of concern for patients suffering from Alzheimer's dementia. I like to talk about the beta amyloid neuropathology, and if you look at the graph on the left, it shows a protein folding diagram in terms of stability and entropy of the system. If you go from left to right of the energy diagram of the protein, left is entropy, lower entropy, and right is higher entropy, and right in the middle is kind of the most stable entropy. And then if you go from top to bottom, top is most free energy and bottom is least free energy. So kind of right in the native state, right there at the green letter A, is where the amyloid protein is most stable. But what happens is a misfolding happens when the protein is denatured. It goes to the molten globule state, and then it aggregates, it forms amyloid fibers, and eventually amyloid plaques. And if you look back to the protein folding diagram, the beta amyloid fibers are not as stable as the native state, but there is a lot of energy required to refold it, and neurologically the brain usually does not supply that energy or have the chaperones and folding proteins required to revert it back to that state. And then if you look at the diagram on the right, it shows a general pathway of what happens with A beta proteins and aggregations. They will accumulate within the extracellular space. They will go on to induce cellular death through the pathways that were discussed in the class, and that in turn will lead to neurotransmitter deficits. Now I'd like to briefly touch upon the tau tangle neuropathology. And taus are the proteins that hold the microtubules together within the neuron. But when the taus do not form right, that is, they are hyperphosphorylated, which is what happens, they separate from the microtubules, and they go on to pair and associate with each other, which causes the neurofibrillary tangles within the sick neurons, as seen in the diagram on the left. And this causes decreased synaptic transmission through the blunting of action potentials and the inability for the neuron to effectively transmit electrochemical signals from neuron to neuron in the propagation of ions. So the current treatments for Alzheimer's dementia. The number one is the use of acetylcholinesterase inhibitors. And acetylcholine, which is a neurotransmitter very crucial and important for memory and learning, is broken down in the synaptic cleft by acetylcholinesterase. And by breaking down acetylcholine, the byproducts, an acetyl group and a choline group, are able to be recycled, reuptaken by the presynaptic neuron, or maybe a microglia will take it up, or some other mechanism. But in Alzheimer's dementia patients, their bodies do not transmit enough acetylcholine, or at least the pathways for memory and learning need an increased acetylcholine activation by the receptor on the receiving neuron. So by essentially blocking acetylcholinesterase from breaking down acetylcholine, scientists and doctors are able to essentially prevent future memory loss. There is no way to restore neuronal functioning, as Alzheimer's dementia leads to a progressive loss of neurons and decreased cortical density. And the big three drugs right now used are donepezil, galantamine, and rivastigmine. That's pretty hard to pronounce, but essentially the mechanism of action is that these drugs will bind to acetylcholinesterase, and prevent them from binding acetylcholine and breaking it down. So it is a competitive inhibitor, so that way the enzyme does not degrade acetylcholine and more acetylcholine is available for the memory and learning pathways within the brain. So the current prognosis, I wish that I could say it was great. It's very bleak at the current moments. There is no way to restore, neural functioning because the neurons die, and neurons, while in certain areas of cortex such as the olfactory bulb and some neocortex areas can proliferate new neurons, these neurons, within, the temporal cortex, they just cannot regenerate. And the frontal cortex, they are just, unable to regenerate. So, using these pharmaceuticals, doctors are able to slow the progression and slow neuronal death. There's no current treatment to prevent future neural death, and hopefully future doctors and researchers will be able to discover a cure for the loss of neurons in Alzheimer's dementia. So a current research lab that I'm a part of, it's called the Information Processing Lab, run by Dr. Chapman, who is part of the BCS department, and also Dr. Mark Mapstone, who used to be affiliated with Strong Memorial Hospital and the Med Center, but now lives on the West Coast. And the research here studies evoked brain potentials in visual information processing, including specific brain potentials which indicate different cognitive events. And after recording the brain activity during each of these tasks, and these tasks are a number-letter study where a series of 2 letters and 2 numbers in random order will flash, and a participant will be asked to respond to either the direction of the letters or the numbers if they were presented in a forward or backward direction, and a cognitive meaning task where many different words are presented to a participant and they are asked to ascribe meaning to the word according to the scales of good, neutral, bad, fast, neutral, and slow, or strong, neutral, and weak. And then after these tests, computer analyses study when the experimental stimuli are viewed, stored in memory, and compared. Participants are also administered a battery of a standard pen and paper neuropsychological tests in a separate study session. And these tests are used as a general diagnostic method to determine the current level of cognitive functioning within the individual. So that is, if they have not been diagnosed with Alzheimer's dementia, they may present some mild and moderate forms of cognitive impairment, which could be considered a prelude to Alzheimer's dementia in the future. And possible future research for Alzheimer's dementia. I've come up with 3 ideas that I believe may prove useful for the medical community. And one would be preventing the formation of tangles and plaques through biopharmaceutical techniques. And specifically talking about the beta amyloid plaques, if researchers could prevent the misfolded state from occurring either through adding a factor to the chaperone which folds it, or preventing it from denaturing, they could prevent the buildup of these tangles and plaques, which are shown to lead to neuronal death. And another idea is developing pharmaceuticals that are better able to conduct current, which is the equivalent of action potentials, throughout the brain in Alzheimer's disease patients, specified to pathways associated with learning and memory, and explicitly the frontal cortex. And this would be maybe through the use of better acetylcholinesterase inhibitors, or maybe drugs that increase acetylcholine receptor density on postsynaptic neurons. And I also believe that researching the underlying causes of the formations of tangles and plaques through retrosynthetic tracing and labeling would lead researchers to be able to prevent them from being formed in the first place. If researchers are able to know what is the beginning pathway of the formations of the tangles and plaques, they could maybe develop pharmaceuticals that would be able to stop it before it progresses too far. And at the end of the day, it's best to get tested early and start treatment early, especially if there is a family history of the disease.